So since we are connected online, we need to stick to the schedule, and we are starting again for this second session. We will have Rafael Duarte, in this case, making a review on liver complications with a focus on veno-occlusive disease, followed again by Sinaida Peric, who will be reviewing chronic graft-versus-host disease. And now in this second session, we will go from the bedside to the bench. And for that purpose, we have Simon Mendez Ferrer, a very well recognized researcher in this field. He has been working and still is working in Cambridge as a full professor, and now is also working as a full professor and researcher in the University of Sevilla and this Biomedical Research Institute. So welcome, Simon. And again, Rafa, please, we wait for you.
Very good. So, so good morning again, everyone. And we're going to be switching gears this time. I'm going to be talking about, I've been asked to speak a bit about liver complications with a particular focus on veno-occlusive disease, on VOD. You've seen my disclosures before. For the purpose of this talk, being as a member of the EBMT, I've been part of some of the guidelines that you'll see published there, and also I work in different capacities as a speaker, as an advisor with Just Pharmaceuticals. That is the company that carries the fibrotide, which is the drug used to treat veno-occlusive disease. So that's the main thing. I mean, liver complications is just so wide. It's just so big. So I decided for this, and having not very much time to go into that, I'll just go to the handbook. And there's a beautiful new version of the handbook that was just released last year. And this is what the handbook tells us about hepatic complications. And you can see that veno-occlusive disease at the top, multifactorial, but then you can have infections, you can have specific hepatotropic viruses, but also other infections. We just heard as well speak Dr. Perich Sina about GvHD and liver GvHD. We've have autoimmune hepatitis, and I think that's also a beautiful concept, and I encourage you to go there. We do have the scans from pathology. We do have a few cases of what our pathologists calls autoimmune hepatitis, and there's nothing else to get her out of there, even though the immune system that is causing that autoimmune is an alloimmune system, and the liver is not the same tissue under the same HLA as it is for Thimba. That's what she calls it. That's what she claims it is. So, and that's the thing, is an interesting concept in parallel to liver GvHD. Obviously, agents, and I put there a list of the agents, and that's one of the first things we have to do when the liver function tests go, a little bit out of range. Cirrhosis coming from hepatotrophic viruses and from other things, and then many, many other things. So, with all that in mind, and knowing that we're going to have to think about many things when liver function tests go off, I want to focus, nevertheless, in VOD, as I've been asked to do. And VOD is one of several endothelial damage, endothelial injury syndromes. And this is a growing list. Again, if you go back to the new version of the 2024 version of the handbook of the ENT compared to the previous one in 2019, there's at least 2, 3, 4 new features. Fluid overload syndrome, for instance, is a new syndrome there. And they're all called, many of them are called syndromes, and they're called endothelial damage syndromes, and they share a lot of the target organs and a lot of the pathophysiology. A slide that I always like to show, and I think that a similar, a different version, Jose Antonio put in his presentation, is this. And I think that this gives the audience something that I think is very real. If we're going to talk about VOD, then you look at it like an academic book. You start the epidemiology and the causes and how do we diagnose and how we treat it. It looks very academic. The real life is not that. The real life is something that happens in between among so many other things going on in these patients. Many things. And if we highlight just out of all those infections, fluid overload syndrome, aspergillus, conditioning toxicity, all that, if we only highlight those that are related to endothelial injury, then you got all those colors there. So it's by no means an easy task to just speak to this about this separately from everything else. And you gotta also take into consideration that the features in these syndromes that we use to identify them, they overlap. And you got there VOD, TMA, engraftment syndrome, all these features, and they share many of these. And then one extra thing. Of course, we're going to focus only on VOD, but one extra thing in the our the mere exam, the access exam for registrars to start training in Spain, and then Doctor House have caused a lot of negative things, because now we think that there's only one right answer. And now we think that everything that happens to a potential patient, it all has to be explained by one single thing. And that is not real life. Many times patients have more than one thing. So let's just also live with the possibility that someone with problems in the liver has more than one thing. And the iron overload plays a role, and some fibrosis from some previous, or cirrhosis from some previous viral infection plays a role. And at the same time, you might develop something else on top of that. And I think that from a clinical perspective is something that we also need to take in consideration. This is the core of it. This is what the clinical features of VOD have been. So rapid weight gain and rising bilirubin and tender hepatomegaly. This is what we know is the key features of the disease. And with this, I'm going to do like with the CMB, what's the history being? The history is being that these papers were published in the late 80s, early 90s, and that we've been managing this disease with this set of criteria for decades, with very little improvement. In Seattle, was a bit more open, and you needed, within the first 3 weeks, day 20, two of those three. So it wasn't mandatory having hyperbilirubinemia. Baltimore was a bit more prescriptive in terms of needing high bilirubin to diagnose it. And all that only within the first 3 weeks after transplant. So that's what we had for several decades. In 2016, we brought a new set of diagnostic, also prognostic, also risk factors, also all the things, but diagnostic criteria. And I think that this was quite a good advancement. This is something, and the reference is there, Muhammad Moti, who's a force of nature, got a large group of people, a large of us, in a dark room in Charles de Gaulle Airport. And then we sort of like were there locked all day long till we come up with something that we could write as a paper for these recommendations. This is how this came about in 2016. And I'll explain the reason for that meeting in 2016 a little later. And this is what we had. At least we had new things. Now we knew that we could have VOD after day 21. And that was good because we had patients with that sort of characteristic after day 21. And before we couldn't call them, name them VOD. Also, the original results, the classical VOD within the first 21 days went into the Baltimore criteria of requiring bilirubin greater than 2. And that is something that's been discussed. And there's different criteria for pediatrics that I'm not going to discuss. And there's other features such as thrombocytopenia and refractory thrombocytopenia to transfusion that in children are more important and better recognized than in adults. That we can do some discussion at the end if you want. And there was something else that was very useful here, is that the late onset for the first time started bringing as well, not only something that depended on just getting two criteria or out of a number, but also it included hemodynamical and ultrasound evidence of VOD. Up till then, we didn't have anything that was diagnostic from a tool perspective. And now we started having that into the criteria. And we also included severity grading. Severity grading based on the key features, but also based on, as you can see there, on the dynamics. It's not only important whether or not the bilirubin is 2.5 or 3 or 4, which is important. It's also how fast you get there. So within 24 hours, 48 hours, it goes, it triples clearly. That is a severe case. And then something quite shrewd that was bringing to that. I don't have slides on that, but something that I think was shrewd to put in there is bringing risk factors as a component of the severity. So if you had a moderate form, and then on top of that you have two high risk factors that made you a patient, that made you into a more advanced form of the severity. These were useful because it helped us guide decisions. And I'll explain the background to that in a little bit. But it helped us not only diagnose patients with VOD, but based on severity criteria, anticipate that these patients were going to need something to be done to them and to guide enhanced vigilance and to inform diagnosis and start of treatment. I'm gonna spend a few minutes now with ultrasound, and that was included in those criteria. I wanted to take a sort of like a look at how we are right now with ultrasound diagnosis of veno-occlusive disease. This is a summary that we did, and my colleagues I want to mention Antonio Colecchia, Francesca Bonifazi, and Federico Ravaioli, because you'll see them next in what is to date probably the best study of this nature that has been done in Italy in immuno-occlusive disease. Lasso's criteria are very old, in 1997, but they worked beautifully. They were done with 100 patients, and they worked beautifully to show association of these features with diagnosis, with prognosis, with outcomes. So what's been the real limitation of this? That we're all just too lazy to do them. There's just no way that your radiologist at home is going to give you a fully detailed score in which he gives you every single one of those score yes, no. It just doesn't happen. It hasn't happened. It hasn't been implemented into practice. And we all get reports, but we all get sort of like descriptive reports. And the way this was used in order to predict, to associate with diagnosis, or to predict prognosis, was giving you a score, a number of points that you got from all this. And we, the majority of us, don't get this. But that is not to say that conventional ultrasound and Doppler ultrasound are not still useful. They are very useful to help us diagnose VOD. But that's how things went. So we had to move to somewhat more simple scores that didn't require 14 different points to be able to diagnose and predict severity of the disease. And then elastography came. Elastography, this is acoustic radiation force impulse RFI elastography. This is cases from our center that Teresa Fontanilla, who's our radiologist of reference for that, published a few years back. And basically what this does is that isolates, like you see in the little box on the right there, a little part of the parenchyma and measures that elastography, which basically is stiffness of the parenchyma. So things that change stiffness of the parenchyma change the results of the elastography, normally measured in kilopascals. And then the combination of ultrasound with elastography can assist in the exclusion of other diagnosis, can be helpful to confirm clinical findings, and then you also get additional information. You're gonna be able to see some levels of ascites if you don't do an ultrasound. There's gonna be additional features that are gonna be of use there. And I'm going to present now was perhaps the still not published, still ongoing review, but was perhaps the most exciting study in this sense. Many of us do pre-transplant and then after transplant elastographies to monitor these patients. But these guys, Federico, Antonio, and Francesca, they led a huge study in Italy. You can see, over 900 patients included, many centers, different technologies, and they did pre-transplant and then did about 1, 2, and 4 weeks monitoring of these patients with ultrasound. They had a rate of VOD diagnosis of around 5%, and then they decided to see what the performance of the elastography did for these patients, and they gave us something that was good. So fantastic study, a huge effort. hundreds of patients, tens of centers all over Italy coordinate to do this protocol. And then they saw this. Basically, they saw an area of kilopascals in which if you're below 6 kilopascals, so there's enough stiffness in the parenchyma, and that you're sure you're not going to have veno-occlusive disease in that case. Then you get those that have over 25 kilopascals, but then the liver is like this. And then, of course, they do have a possibility of having veno-occlusive disease because it's very rigid. It's very rigid as a result of the microthrombi and the congestion within the parenchyma. But then they identified this gray zone in the middle from 6 to 25, which is really too wide. And then what they saw here is that they had a previous uh, um, elastography result, and then whichever was the diagnostic, they were double that previous level. They could use just as a marker, and that would associate with having veno-occlusive. That increase in the stiffness of the parenchyma. There's limitations here. I think that this is a great study. This is how they designed it. This is how the statistical analysis went. Most tests that we measure, we don't say, twice over the baseline. We just say twice over the upper normal limit. So what's your high bilirubin or what's your high LDH? So I think it's going to be high and high risk if it's 1.5 over the upper normal limit. And that's how you normally measure that. However, they wanted to bring all these into the equation and they put the baseline. I think they probably work just the same. So you're talking there that in those ranges is not only how much you have is whether it's twice or more over the normal limit. Uh, Good things is that the elastography increases in patients with VOD and correlates with VOD severity, and that's been shown by this trial. It'll be published hopefully soon, and that proves that the technique works in these patients in a trial fashion. Then pre-transplant elastography did not correlate with hepatic VOD, and that's the same thing we're seeing in my center. We got over 300 patients treated with, and then with pre-transplant elastographies, and we don't see an association of pre-transplant elastography with the risk of developing VOD. But they claim that is nevertheless needed to do this ratio assessment for the gray zone. And I claim that it is something that might be necessary. We still do it nevertheless, but it might not necessarily to make it so difficult on other centers that don't have the same availability of doing ultrasound and elastography quickly. Maybe just twice the normal range should be enough. And then they design a stepwise algorithm that in which in different forms should be a model to apply in different centers. We don't use it quite like this. We don't use it at fixed times, day plus 7 plus 14, because we have the capacity that as soon as we have a clinical suspicion, our radiologists do the ultrasound within the day or latest the following day, within 24 hours, and they do the elastography as part of that. So we do it in a response to the symptoms rather than a planned manner on prefixed dates. So we discussed the original diagnostic criteria. We've seen how that changed in 2016 with the new criteria of EBMT, and we've discussed how that helps us not only diagnose but disability, also anticipate the possibility of the occurrence of the disease. And we know now also this new novel diagnostic test that might have application. So we created new diagnostic criteria, and there's been a couple of these. There's been this Cairo criteria that is really for colleagues doing a modified diagnostic criteria gradient classification for VOD, and then this study, which is the follow-up, the refined classification of VOD. We published this in 2023, so from 2016, barely 7 years after the original review. And I'm gonna go through that with some detail. First thing is that even with the new criteria, we were missing some things. Early diagnosis can remain difficult. You remember how many different features and how overlapping between different complications. Then there was something that we had developed in other areas, and that was commonplace. You all know that when you have to manage fungal infections, you need to assign that. It doesn't serve any purpose to just call about a fungal infection without saying it's possible, it's probable, or it's proving. Because not only for level of certainty, but also because then you can compare pears and apples with apples. You need to have that kind of information to be able to put in the same pot cases that are similar. And then we needed that sort of probable clinical and proven classification. And then out of the first classification, the early classical and the late onset were different in terms of diagnosis. And we thought that in reality, the only thing that needed to differentiate that was the time that it occurred, not so much what diagnostic criteria you use before or after. So all these things, and then elastography had to be built and brought further into those criteria. And this is what we ended up doing in 2023. The classical hepatic VOD is whichever criteria up to day 21, and the late onset is the same criteria from day 21 onwards. And I think that that's an improvement. And then we created this probable category in line of what the original Seattle modified criteria were. I was just taking two of the following criteria being present as something that you can call VOD, and that is a good thing. I've treated out of the patients with severe veno-occlusive disease that we treated in my department with the fibrotide, a third of them did not have a bona fide diagnosis of VOD the day that we started the fibrotide. And we started because of severity, we started because of this, other factors. But following the 2016 criteria, they didn't still fit criteria. So that's something that had to be fixed. And maybe some of these patients would have maybe some patients that would have been just a probable at that point, and that some of those problems might have just gone back and it never materialized into a bona fide VOD. But we needed to have some form of label diagnosis to tag those patients. And this is the probable criteria: bilirubin, painful hepatomegaly, weight gain, ascites, and ultrasound, all at the same level to diagnose a probable form. The clinical form remains, and this is something where we'll have to see whether we revise in the future, but remains a Baltimore driven. Remains still bilirubin is a requirement. And we know that this might be questionable because the more we look into it, the more we see that in pediatric is half or more, but even in our patients at the moment of diagnosis, there's over a third of patients that are not high bilirubin. So what happens is that you'll be transitioning from a probable diagnosis to then a bona fide clinical diagnosis when the bilirubin goes up. And at least that gives you also a dynamic of diagnosis in this patient. And then proven is more clear and it's there. You got here in a table something that Alba Puyuelo, when working in our department, put together that was a comparison between the ABMT 16, the 2016, the Cairo criteria, and the ABMT 2023. For instance, just to mention one thing, the criteria go in different directions. Some criteria want to be very sensitive to be able to make sure you don't miss anybody, and some criteria require. That's why I think that having the open capacity not to miss patients, but at the same time, the level of stringency of diagnosis incorporated is useful. Cairo criteria, the painful hepatomegaly is two criteria. So pain, right upper quadrant pain is a criteria, and hepatomegaly is another criteria. So if you got just painful hepatomegaly, you got a VOD. So how many patients do we have that have a painful hepatomegaly and don't necessarily have any of the other features? So I think that all these need to be taken with a pinch of salt. And then those are the comparison. These are patients, and we look at 40 patients diagnosed and treated with the fibrotide for veno-occlusive disease. Those are the characteristics. As you can see here, we have a pre-transplant liver ultrasound that was normal in 70%. There was around 29% that had some steatosis as the only finding. The elastography, as you can see, for the most part was normal in all cases, around 4.9 from 4 till 6. And there's a few that have, those with mild liver stiffness, those had a bit of a higher kilopascals when prior to transplant, but still none of that predicted. All these developed VOD, and as you see, the majority had normal elastographies and normal ultrasounds prior to transplant. So it doesn't really help to predict. Those were, of those, 72% responded well to the fibrotide. Those are the median days of the fibrotide treatment. 12 of them required ICU admission, and overall, 11 cases, 27% of those died. So reasonable results for a very severe complication. And then the radiologic findings at baseline did not seem to be able to predict the occurrence. At further diagnostic testing, they were suggestive in 24, 60% of those cases. And I think that that's important, but it also brings something into the discussion, because it's very good when you have the suspicion, you do ultrasound, the elastography, and it's sort of suggestive, then you start treatment right on the spot. You don't have to wait for anything else. But what happens if you do the test and the test is still not clear? More in a situation like ours, because we don't, this test we do immediately. If we have the suspicion today, the ultrasound will be done this afternoon or tomorrow morning. So maybe it's a bit too soon. So we had 40% of those that at the time that we had the suspicion, an ultrasound came back, an elastography came back normal, negative. And that, in many cases, prevented us from treating and held back treatment for at least a median of 2 to 3 days, 2.5 days. So beware of how you implement and how you use elastography in your centers when you start implementing it, because it's going to be very useful, but it also might mislead some therapeutic decisions in these patients. That's a picture that basically tries to look at the dynamics. So basically in orange you see the period that those patients were treated with the fibrotide, and then the gray circles are ultrasounds and elastographies that were normal, and the red ones, the one that confirm the or indeterminate, and the one that confirm the diagnosis. And then the question is that there's many of these. All these are the specific findings that did have and specific findings before, but then went on to have the proper diagnostic ultrasounds, and sometimes delayed that for a few days. This, we did the validation of the criteria with these 40 cases, and I'll go just quickly over that. You can see that our practice is that around 55% of our veno-occlusive disease are icteric, but 45% are anicteric. So at the time of the diagnosis, the bilirubin is still normal. And that's one of the reasons it becomes higher later on. But at the time that you have to make the decision to start treatment, is still not raised. Then 63%, 62% of those are classical within the first 3 weeks, and then the rest are later onset. And then that's the distribution of severe. Around 60%, 57% are severe, and then 42% very severe. If you look at Cairo, of course, is more is a more sensitive approach. As you can see here, only 26, 65%, 2/3 of our patients met criteria, diagnostic criteria at the time we started treating. With Cairo, everyone would have met those criteria. They're very, very open, and that is good. That's reassuring. What we don't have here is how many of the many other transplant recipients that never have VOD or were treated would have also met Cairo's criteria, and that would have been a difficulty in applying this prospectively. And this is the event 2023. I think that's something good in finding a middle point with this classification of the probable versus the clinical. The probable gives you pretty much the same thing as Cairo. Everyone gets identified. Now, all the patients that we treat would have at least a probable diagnostic criteria tag to add to the patient before we start treatment, at the time that we start treatment. And then you also see, as a result of that, that more of those are anicteric, because you identify those at a time when still bilirubin hasn't raised in all of this. And then most of those are early, because in reality, some of these are actually in the transition happen. And if you diagnose it a little early it's day 19, 18. If you take a little longer, it's day 21, 20, 24. So that's the difference. And then you also get less very severe forms. And that's a good thing, because you want to treat these patients intervene before they are down, going to multi-organ dysfunction. So that is a good thing as well. And then, however, the clinical keep the reassurance of results more similar to what the classical results are, including more very severe forms, including the fact that these are, of course, all icteric, because high bilirubin is a requirement for a clinical diagnosis. And I'm finishing this a few more minutes speaking very generally about the fibrotide and about treatment. And this is the kinetics of use of fibrotide. In 1988 was the year that I finished the medical residency. In 2002, a couple of years later, I moved to the UK, and I was working at the Royal Free Transplant Program. Royal Free Transplant Program, Graham Prentice, I was the head of the department, was one of the people interested in all this field. And a good percentage of my time as a transplant coordinator, as a registrar there, was filling out papers to get the fibrotide from this Italian company that sent it free, but you had to actually send all these papers. So we had this drug free of charge for decades and gaining a lot of experience. The International Compassionate Use Program is one of those. We applied it in treatment and we applied it in prophylaxis with doses that are different to what's being approved in the label later. Then the TIND study came later. And then October 2013 is when it was approved in Europe. It's one of the few drugs that gets approved in Europe first, and then it goes on to be approved at FDA in the States. So mm, a lot of the developments in the field have been driven by the arrival of the fibrotide. If you don't have anything to offer to the patients, there's not much point sitting down to try and figure out diagnostic algorithm, treatments algorithm. How do we do all this if we don't really have anything much to offer the patients? But the arrival, the experience with the fibrotide has driven the field in a lot of ways in this group. And there's many studies. I'm just going to give you 3 slides about the TIND to give a general picture of what we know now about the treatment. This is over 1,000 patients included, so this is a big study. The dosing of the fibrotide has been defined 25 milligrams per kilo per day. As said before, normally standard dose we would apply before that was 40 for treatment, 20 for prophylaxis, and nevertheless it also seemed to work. And these are the features. Clearly, you respond better depending on the time of initiation of therapy, and this is 100-day survival. And if you start within the first 48 hours, your patients are going to do better than if it takes you a week or longer to initiate treatment. And that's for all patients. And then for patients particularly severe, patients with multi-organ dysfunction, impact of timing of survival also has, this is looking specifically within the multi-organ dysfunction severity, depending on how many organs you have affected. So this is all patients with multi-organ dysfunction. This is those that don't have ventilator or dialysis, and you can see that the survival 100 days is 50 plus. These are very severe complications. You cannot waste time with this. But then if you have only one of them, or if you have more than one, and if you have in particular both ventilator and dialysis, then your chances of survival, even with the treatment, are less than a third, are around 29%. Don't wait for treatment. And then something else, which is part of what the decisions we have to make, and is how long do we treat for? The label is 3 weeks of treatment, and that's sort of like the standard we keep. Our treatment, our average day of treatment median duration of treatment is 14 days, is 2 weeks, because there's also patients that we treat as a probable initially, and then you find all the things, and you see in this differential diagnosis that there's all the things happening that you treat, and then we end up discontinuing treatment earlier. So it can both ways. But if you look at here, there's about half of patients who achieve a complete remission require more than those 3 weeks, 4 or 5. Of course, it's something that needs to be discussed, something that needs to be brought into protocols. Cost of the fibrotide is huge. My ICU guys that treat very severe patients, but treat them with corticosteroids, antibiotics, and very cheap drugs, they always come knocking on my door as soon as there's a couple of patients that come down to ICU, because 20% of their overall pharmacy budget turns to the fibrotide. So it's something that needs to be brought into protocols as well. But I think that we can conclude that liver complications overall are are one of the most difficult to manage. They're common. Fortunately, a lot of those common complications are drug related, drug induced. There's many other things in which the liver is part of a broader context of complications. GvHD is one of them, and we've seen GvHD of the liver. I overall are quite prone, as I said before, for GI biopsies. I'm quite prone on biopsying overall. I think it's good, and we have, fortunately, for this, for liver, we have very good support from our colleagues to both parietal and transjugular. We do biopsies of patients quite often. If there's a patient and that Ana Carlos, where there is a patient in outpatients that comes with liver dysfunction, and then after a couple of weeks that doesn't seem to settle with early changes, we bring that patient in to biopsy the patient, even if it's just to biopsy the patient and then send him back. And I think that that's useful for us. In terms of veno-occlusive disease, it continues to be one of those many complications of the liver, but with some good things. First, that we have a drug that we've used for decades, but that's been approved since 2013, that does the job. And it doesn't do a fantastic job, but that's the best job we've seen done in these patients. The rates of response are a bit over 50, 60, 70%, depending on the patients. And then we need to reorganize the rest of it to try and make it work as effectively as possible. Early intervention. We need to be able to look at how the new diagnostic criteria really help us to do this. Ourselves have our own experience. There's colleagues from other places, from Salamanca, Marta, there's a lot of other colleagues that are looking into these same questions, because if you're going to spend a lot of money in curing this complication in these patients, at least you do it right and you do it at the time that is going to make the best benefit. And then new diagnostic criteria is the other thing. I think that you need to try and work out with your radiologists how to implement this and how to put it in an algorithm at your center that works. If it's not something that can be rapid response upon clinical suspicion like we fortunately have, then you might want to set up at least a day 7, day 14, and then see, pre-plan how those livers are, how the stiffness of the liver is, and that'll help you definitely predict and hopefully manage more efficiently these patients. And I think that's it. Thank you. I'll be happy to take questions. Thank you.
No. Thank you. Thank you very much for this excellent review. We have time for a few questions. Okay, so I will start with one of them. What is the specificity of the new criteria, particularly for probable? Are we making too many diagnoses since
Absolutely.
the...
Yeah. That is the key question. I mean, that is the key question. But I think that is why within the sort of like range of grace, these probable criteria within the new criteria, at least it make you aware that what you diagnosing VOD is a probable diagnosis only. So we have to prospectively, and that's the problem. I mean, the problem is that retrospectively, what we did, which is looking at our diagnosis already treated, of course, all those 97.5%. So pretty much everyone but one, all by one, met the criteria. But how many that we never treated, we never thought would have just met those criteria at some point, and we just didn't look at it. That is something that retrospectively is very difficult to do. It's very difficult to do. So I hope that, and that's one of the things that we're trying to generate is a prospective validation of the criteria. And nevertheless, even with so, the choices we have right now is VMT, or we got the Kairos criteria. And something very similar, we're going to talk tomorrow about TMA, something very similar is going to happen with TMA. All these criteria are based not on good diagnostic tests that give you good sensitivity, specificity, but on clinical cohorts of features. Those we need to be careful what the specificity is in those. So it's an issue, it's something to resolve, it's something to test prospectively. I don't think that there's any other way to really test it. But at the same time, I think there's still a step ahead to management of all those patients that before in my department, we would treat with the fibrotide, even without a probable diagnosis. And we just hope for the best. And then 2 days later, they were ready at the level of the clinical diagnosis, but not at the time that we started. So it's a weakness. It's definitely a weakness of the criteria.
Mm.
Yeah.
Okay, and the other comment in this regard is that, I mean, the drug has been tested in a very particular situation with a specific diagnostic criteria, whatever. And now we are changing basically the scenario. We really don't know whether or not the drug should work in this subset of patients. So I think that should be mandatory try to perform some kind of trial to see whether or not we are offering any benefit
This
in
is
this.
that's a very good question. That's a very pertinent question from a scientific perspective. Absolutely, because but I think that this is all being recorded and said. I mean, I mentioned briefly. I think that's been a positive thing. I mentioned before, Jose Antonio, that the approval was in 2013. There's like always in this thing. I was one of the group of advisors with Mohamed Moti, with Tony Pagliuca, with Paul Richardson, and with Enrique Carreras. There were five of us that went sort of like to IMA and see and present our case with the company. And it was strange because we had all this data from TIND and from all the compassionate use program. The trial that I haven't mentioned is the pediatric prophylaxis trial, the randomized trial that was done and that showed some potential benefit in children, not for adults. It was a prophylaxis trial, and still the sort of final agreement, having nothing else to offer and being a very severe complication. Of course, this is over 10 years ago. With the agency was that we had to find a common ground to be able to not leave these patients unattended and at the same time try to be guided. So that is when the severe VOD description was. It didn't come from really trials that only treated severe. It came from, well, of course, in order to treat, you treated patients with different levels, no? And there were studies that would just focus on multi-organ dysfunction and the big things. But it was more a compromise of how you manage risk and benefit than anything else. There was the threat of bleeding with the fibrotide that is always there. I think that overall is a very safe drug, and we haven't had major issues with that or major reports since it was approved of problems with that. And then the way we did is that, and that's why that was done in 2016, is that 2013 we had the approval, and the approval was specifically for severe forms. And then at the same time, we wanted to be able to benefit our patients as most we could. And then when the criteria are very strict, then an alternative is to reevaluate the semantics. And part of the criteria for severity, a part of the criteria that the risk factors are part of the overall context of severity scoring, comes to the necessity of patients that are not the multi-organ dysfunction patients that, if they are already in dialysis and intubated, those are going to survive, 30% of them are going to survive, was to try and improve earlier patients. So I think that in a way, we've sort of adapted to less severe patients just by changing the semantics in the criteria. And that's why that came just a little later in 2016 after some experience and after see that if we only did the very severe ones, we were leaving out of the equation a lot of patients that really needed to benefit from that as well. So we did that, I think, inadvertently in the way that those criteria were created. And I think that gives response to some of those earlier forms. Nevertheless, if we go to criteria that are very open and that let pretty much everything in, going, then the question would be whether those patients need treatment at all, not anything else. But yeah, I think I don't think that the drug will not perform in only probable forms of the current criteria because those are sort of incorporated. We were treating them. The only thing is that before I was treating them without the tag, and now I'm treating them with the probable VOD tag.
Any more questions or comments? Okay, so we are perfectly on time. Thank you very much.
Thank you so
Rafa.
much.
So again, the next talk by Sinaida, she will be focusing now on chronic graft versus host disease. This one, yeah.
Thank you. Once again. Well, it is always a challenge to make a chronic GvHD talk exciting before lunch. But I will try to give an overview of chronic GvHD in a, let's say, how to manage manner and try to tackle all parts a bit on how to diagnose and score, how to treat first line, how to follow and evaluate, how to treat second line, and last but not the least, of course, the most important, how to improve quality of life additionally besides the treatments. So we are still talking about chronic GvHD, unfortunately, because it still is the big cause of morbidity and late mortality. This is because, of course, we are using older recipients, more peripheral blood stem cells, and the incidence is still not decreasing. We in time we have learned a lot by about the clinical presentation and about the pathophysiology, which are pretty much very different from acute GvHD. And we know that chronic GvHD resembles any autoimmune disorder and that can literally affect any organ, mostly affecting skin, mouth, and the eyes, and that it usually happens in a three-phase pathophysiology way. Where actually the cardinal last feature is fibrosis, which is unfortunately irreversible at late stages, and also responsible for the most severe presentations of chronic GvHD, which are skin sclerosis and lung GvHD. It usually happens in the first year after transplantation. So most of the cases, more than 90% will be diagnosed in the first year after transplant, although we know that there are very late cases up to 7 years after transplantation as well. But what is most important when we talk about chronic GvHD is that the fact that chronic GvHD significantly worsens quality of life of patients. It has been shown in many ways. This is one of the ways in a large CIBMTR study where actually the quality of life decreases in relation to NIH grade of chronic GvHD. But these patients in general have lower performance status, higher symptom burden, more likely are taking medications. And 1/3 of these patients who have active chronic GvHD are unable to work, with another more than 10% who are unable to work even if GvHD resolves, meaning that almost half of these patients will not work or not be able to return what we say normal life. And this is what we usually refer to when we say going back to work. So how do we diagnose and score chronic GvHD? We know that this is not always an easy task. I always like to do it to simplify it by a practical thing and a real patient, which in this case is a young myelofibrosis patient who had a 10 out of 10 unrelated transplant with peripheral blood stem cells, had an insignificant early course, and then had acute GvHD of skin and liver with steroids needed to be initiated, but with extreme toxicity of steroids, with all possible side effects of steroids, which she could not support at all, although being pretty young, which made us to stop steroids and start mycophenolate. And then 2 or 3 weeks later, she came back with very red eye, very red mouth, very significant mouth ulcers. And I was a physician, younger physician at that time, and I presented it to my senior colleagues. And we all agreed that it must be signs of chronic GvHD. And what has been used for now some time, and we know it pretty much well, although still it's not very simple to use it, are the NIH 2014 criteria, which are the most accurate and widely accepted standards for diagnosis and scoring of chronic GvHD. And when, for example, you need those criteria, you either need a diagnostic criteria or you need this. If you don't have a diagnostic, you need distinctive or other with something else. When it comes to the eye, there's actually no diagnostic criteria. What was good in that point of time with this patient, that we had a multidisciplinary team involved in new chronic GvHD patients, as she was instantly seen by an oral specialist and ophthalmologist. And they said, wait, it's not GvHD of the eye and mouth, it's actually a very severe herpes infection. And of course, this is not the point of this is not to say that we didn't know well. The point is that we couldn't know it well, because unlike in acute GvHD, where we can really rely on our clinical experience, in chronic GvHD, being it such a heterogeneous disease with many clinical presentations and organs that we do not expertise in, IGVHD cannot be differentiated from infection, at least from a hematologist's point of view, because for us the red eye will be the red eye. And actually this is what the NIH criteria, if you read it very carefully, says, that if you don't have a diagnostic criteria but have a distinctive manifestation, then it's not enough. Then you need a biopsy or lab or other test or evaluation by specialists, and they specify exactly an ophthalmologist and a gynecologist. And I think that's not by chance, because these organs are probably the most hard or the most difficult to manage if you are a hematologist. So obviously you cannot do an eye or gynecology exam by yourself. And also infection and other causes can confound or really complicate the differential diagnosis, like it was in this case. And therefore, I think the first point that I always want to make is that a dedicated multidisciplinary team is a crucial thing whenever managing patients with chronic GvHD. And even if you don't have a multidisciplinary team and you need to choose specialists to collaborate with, well, you need at least an ophthalmologist and gynecologist in your group of people. I come back here again to the EBMT, the NIH EBMTR position paper by Helen Shermans, which I always try to highlight as help for better understanding also the NIH document. And I will try to give you some practical tips throughout this talk. The second patient is a 25-year-old CML patient who had to be transplanted and had a good matched female donor and received bone marrow. Had no acute GvHD, but then had a mixed chimerism at day 180. And therefore received DLI. Soon after elevated his transaminases, which was of course attributed to DLI, but then several weeks after developed skin rash and diarrhea specific for acute GvHD, and then mouth ulcers and keratoconjunctivitis, again specific, something that looks more like chronic GvHD. From what we know about GvHD, we of course know that besides classic acute and classic chronic, we have overlap GvHD, which is chronic together with acute GvHD manifestation, and that is pretty clear that that's what happened in this patient. And I've mentioned it before. Manifestations of potential alloreactivity, as well as those increase in liver enzymes due to DLI, are actually defined and let's say even treated as chronic GvHD as well, and not acute. Every time we need to evaluate a patient for chronic GvHD, and we should do it at every clinical visit, it can be probably easier if we focus on some of the key questions and key elements of physical exam. It is simple to focus on 10 important questions, and also to perform at least weight, performance status, range of motion, skin, oral, and eye exam. And with this, we can be sure that we will not miss anything important in terms of chronic GvHD. So if we do it at every clinical visit. And there are many useful tools online that we can use to not to forget any of these. And then if we are happy, or we can establish a multidisciplinary group of people, then it would be useful to have, as I said before, at least an ophthalmologist and gynecologist. It would be useful to have an oral medicine specialist, dermatologist, nutritionists, and physiotherapists. And what we also always have to have in mind is to do the pulmonary functional tests at least every 3 months, and at least in the first year when most of the GvHD, as I said before, is diagnosed. And we know that pulmonary symptoms in GvHD of the lungs develop when it's already too late. All these visits do not need to be, of course, done at every visit. That's 3 to 6 months if a patient has some of the presentation at the diagnosis, but by the need if or when clinically indicated, once that chronic GvHD has been diagnosed and manifestations in these organs were excluded. Once we've diagnosed it, we need to score it, which is even more complicated because we have 8 organs, scores 0 to 3, and scoring gives us a definition of mild, moderate, and severe GvHD, which we know is important for the treatment. And of course, we also have some online tools. There's a very good eGvHD app, which I recommend always, which can really help us make the diagnosis and scoring much easier. Once we've diagnosed it and score it, we need to decide who to treat. Obviously, my first patient was not for the treatment of chronic GvHD, but for the treatment of HSV infection, which, by the way, looked very impressive and required the recovery of a month as an inpatient. But as it usually happens in the field of previous infection, it is easier for chronic GvHD to develop. And she actually, a few months after, developed symptoms again with the redness of the eye, but this time signs of chronic GvHD were present. And this turned out to be a pretty severe chronic GvHD with score 3 in the eye. And according to the NIH criteria, if you have either 3 organs or more with score of 2, or 3 or more organs involved, or a score of 2 or greater in any single organ, systemic immunosuppressive treatment should be considered. Therefore, she was considered for systemic treatment, which she didn't want to hear of at all, because she thought that steroids and immunosuppression led her to that horrible HSV infection, and we could not say, well, that was not the true. And therefore, we thought of what to do, and what should we do? Should we try local therapy or insist on systemic one? And according to the NIH criteria, actually in organs such as mouth, eyes, and genital tract, aggressive local therapy can even be reasonable, as a response to systemic therapy may be suboptimal in these patients. And of course, this is the type of the patient, because she had only the eye severely affected, later on the genital tract. But of course, what we always have to have in mind is our judgment, and be flexible when suggesting the treatment to a patient, and of course, modify decisions according to comorbidities and infections, as it happened in this patient. In my second patient, we had severe overlap GvHD, which is an indication for systemic therapy for at least 1 year for all moderate and severe disease chronic GvHD patients, according to the NIH criteria. And that is usually steroids, milligram per kilo, with calcineurin inhibitors. It is easy to introduce the treatment in chronic GvHD, but as we mentioned, it is not easy to taper it off. In chronic GvHD, even more, because we are always, well, at least I am impatient to get patients off immunosuppression. However, the second name of chronic GvHD is patience, and you do not do anything abruptly. And there are some nice expert reviews. This is one of them, which have really detailed, let's say, detailed instructions on how to gradually reduce steroids. So 20 to 30% dose reduction every 2 weeks, and in case of exacerbation, then increase by 2 levels, and then wait for 3 months before you proceed. What we also have to have in mind that chronic GvHD decreases the survival of patients, and large registry studies have shown that this is because of higher transplant-related mortality. Fortunately, not because of relapse. It does not, well, not fortunately, but it turns out that it does not protect that much from relapse as we thought it would. But the what I wanted to highlight here is the thing that actually patients who do not have GvHD and have an ongoing immunosuppression, we have data showing that these patients have an increased chance of relapse. Which brings me to my next point, and that is that chronic GvHD should be managed with the lowest amount of treatment as possible in any time point. In order to do that, we have to regularly evaluate patients, meaning that every several months, usually every 3 to 6 months, we need to reevaluate chronic GvHD, because unlike in other autoimmune diseases, in chronic GvHD, clinical tolerance eventually does emerge. Median of immunosuppression treatment is 2 years. And by systematically evaluating these patients, even irrespective of any change of treatment or symptoms, we are sure that we won't miss this moment of clinical tolerance, meaning that the point is to calibrate the treatment periodically by lowering immunosuppression to allow chronic GvHD to emerge before increasing the dose. When we talk about follow-up of these patients, supportive care is crucial because, as you can see here, patients who have immunosuppression at 1 year after transplant die more than they die mostly of infections. Therefore, it's very important to have prophylactic treatments for bacteria, viruses, fungi when they have steroids. And what is also, I think, important in these patients, because one size doesn't fit all, not to have some time period of continuing this antibiotic, antiviral, and antifungal prophylaxis, but to follow immune reconstitution in these patients, which is, let's say, an easy test, which can really help us to see how much these patients are still immunosuppressed. This brings us to second line, and my third case, which is a bit more complex. A patient who had secondary AML and needed a transplant, had an all risks for having GvHD because got an unrelated, although well-matched transplant from a female donor, and had obvious risk factors for complications afterwards, because before transplant he had bronchiectasis, had acute GvHD, he had CMV reactivation, and then, as it sometimes happens together with signs of acute GvHD, he had also a decreasing chimerism. So we were worried of course, relapse, and therefore we started with local steroids, both for intestine and for skin, and actually had some success here. With still a mixed chimerism, tried to taper off cyclosporin. That was too brave, because soon after he had respiratory symptoms. Although we did achieve the full chimerism, we also achieved that he develops lung GvHD as well. His FEV decreased to 50%. We tried to try with FAM in order to lose the minimal residual disease, but then we had to start systemic steroids because there was no effect. And after 2 months of steroids, had no response in terms of improvement in FEV, but had some clinical worsening, which we worried was due to GvHD, but it actually was a series of infection. We started with COVID, with Pseudomonas, and then further decrease in his FEV, and then another infection, which made us actually start treatment which we thought was the least immunosuppressive, and that was ECP. However, did not help us a lot, because then had another series of pneumonia, and finally it brought us to the FEV of 31%. which brings me again to the definitions of steroid refractoriness and steroid dependence, which I think are not the problem, but it's steroid intolerance. Is it what actually can we say is steroid intolerance? We say it's unacceptable toxicity, so it's is it diabetes or hypertension, or are those also infections can be seen as a complete intolerance of steroids as well? As you can see, I think it's a classical complicated case where we are fighting the minimal residual disease, the chimerism, and the lung GvHD, for which he was had predisposition. When we talk about second line, well, today we are much happier because there is something to be offered to our patients. Until 2021, we had only one agent available, and it was thought that the reason for that is that the clinical, because of so heterogenetic diagnosis with problems with staging, so this is all for what the NIH consensus efforts were done, but also in terms to homogenize the criteria for responses in clinical trials to be able to conduct the clinical trials, because it was not easy to define clinical endpoints in chronic GvHD as well. We always look at overall response, which is a short-term clinical endpoint. However, long-term survival is something that we wait too long. What this NIH effort also brought is a definition of intermediate clinical endpoints, and these are the failure-free survival at taper of steroids, and that is something that has enabled phase 2 studies, and that actually led to clinical trials that at the end turned out to be successful and brought new approvals. The trial that proved that failure-free survival works is this one published almost 10 years ago in Blood, where failure-free survival was actually analyzed and showed that after second-line treatment is 57% at 6 months, 45% at 12 months for the treatments available at that time, and that the most actually frequent cause of failure-free survival is the change of treatment. And with this shown to be a meaningful endpoint for clinical trials, trials were conducted and led to approvals today of 4 drugs in last 3 years. Actually, ibrutinib we had from 2017, but then we got 3 approvals in 3 years, and chronic GvHD is now looking a bit more different. We know that all these drugs work in a different way, and with the knowledge on the pathophysiology of chronic GvHD and all that we have learned from the trials about efficacy and toxicity of these drugs, have to have all this in mind when we are today choosing an agent for each patient, if we have, of course, all these agents available. So first drug approved was ibrutinib. We know the trial. It was a phase 1/2 trial in patients who failed 1 to 3 previous therapies. It was mostly skin GvHD. The overall response was 67%, mostly partial remissions, and the response was sustained even at a median follow-up of 26 months, with a failure-free survival of 50% at 18 months, which compared favorably to historic benchmark of 35% from the study that I've shown. However, we know that ibrutinib, and that's what we see in real life, is a pretty toxic drug, not so much in the trial, but it does lead to discontinuation in real life patients. In trial, it was due to side effects in 33%. Back to our patient, at that time, we didn't have any choice. We had only ibrutinib, and we started to, although he had those relapsing pneumonias, which of course is not perfect for the drug, but we started ibrutinib. and continued this treatment with the immunosuppression that he had. He had atrial fibrillation, which is pretty classical. And that at that time we had some new approvals. So ruxolitinib was the drug that we had first after ibrutinib. So we know that the ruxolitinib was approved after a REACH-3 study, which it was compared to the best available therapy. And it was actually the second line drug in steroid refractory patients. And here it compared favorably to best available therapy, 50 to 25 responses with a small part of complete remissions, but still significantly higher also overall response and symptom response on the Lee scale. And when it comes to failure-free survival, 75 to 45%, which led to its approval by FDA in 2021 and then by EMA in 2022. What about side effects? Well, we know them already from acute GvHD. It's similar. It's infections, but although grade 3 infections were similar in the both arms, around 20%, and 16% had to discontinue treatment due to the adverse events. What about ruxolitinib third line? I'm asking that because our patient already had steroids and ECP and had ibrutinib. Does ruxolitinib in third line works as good as in second? Well, in the REACH-3 study, the crossover at week 24 was allowed, and therefore we can know this answer as well, because the overall response was actually pretty similar as for ruxolitinib as third line, as well as were toxicities, making the conclusion that ruxolitinib has high efficacy and manageable toxicity as third line as well. Our patient actually after 1 month of pneumonia and after 1 month after pneumonia had actually another complication that was connected to ibrutinib, and that was actually a huge bleeding in the skin. A large hematoma. We know that ibrutinib, from ibrutinib from before can change the thrombocyte aggregation, and therefore we had to stop ibrutinib. Soon after, he developed hepatic lesion as well, and his FEV was, let's say, relatively stable. Therefore, we initiated ruxolitinib. He developed anemia and thrombocytopenia. We decreased ruxolitinib, and we continued ECP and cyclosporine, but this led to another infectious complications, and finally a problem that happened with his central venous catheter, which is always a problem when we are doing ECP. So even with lower thrombocytes, he had actually the thrombosis of central venous catheter. We had to stop ECP, and he was started on low doses of low molecular heparin, which then with even better levels of thrombocytes led to another problems with bleeding, and then everything was stopped. However, his FEV further decreased, bringing us to the point where we actually didn't know what to do, because we did not have belumosudil available, and that was the third agent approved at that time. We know that belumosudil was approved after phase 2 studies. So those finding studies were in 50 and 130 patients after 1 to 3, and then after 2 to 5 lines of therapy. So at least as third line, and showed overall responses of 65 and 76% in the second study. And here we learned from the study that among organs it worked in all organs, and that it had very good responses in some of the hard to treat joints and fascia and skin lesions, so the sclerotic forms, and had some success in lung GvHD as well. And FDA approved it in July of 2021. The FFS was 54% at 12 months, so comparable to the other drugs. And when it comes to adverse events, 20% of patients discontinued treatment due adverse event. My question, of course, would be, what would you do with this patient? Today, when we talk about lung GvHD, beside belumosudil, so the most sclerotic, fibrotic forms of skin sclerosis and lung GvHD, one other agent has been approved in the meantime, and that is axatilimab, which was approved after a phase 2 randomized study in patients with recurrent refractory GvHD. And here, dosage of 1.3 milligram per kilo every 2 weeks has been found to work best. So 74% of overall responses and 60% for a 5-point symptom response for this dosing. And also, again, failure-free survival at 1 year around 50%. And also, when it comes to different organs, organ-specific responses were observed across all organs, including in the organs that had the most fibrotic changes. And when it comes to adverse events, the most prominent ones were the transient laboratory abnormalities, but adverse events led to discontinuation of only in 6% of the patients. So are we now ready for the treatment individualization in steroid refractory chronic GvHD? We, of course, do not have head-to-head comparisons. But once I don't know, what is your experience? Do you have those drugs available? Some belumosudil was available on compassionate use for some time. When we have all these drugs available, we will have to think widely. We will have to think, first of all, in a patient with chronic GvHD, if we have many organs affected with chronic GvHD, which organ are we targeting, knowing the efficacy of these drugs, with knowing the toxicities and previous toxicities in these patients, which should also be taken into consideration. Also, we have to take the biology of GvHD and the way those drugs works, especially when we try to combine them, because of course, with the fact that all of them are bringing to partial remissions, it is becoming interesting. Well, the idea of combining them together, we of course do not want to combine the drugs that work in a similar way. Apart from that, are there any other ways to improve quality of life? Where obviously there are. I have mentioned it at the beginning, so I like to end with it as well. The multidisciplinary approach is crucial. This is the approach that helps us in diagnosis, helps us in improving the treatments, and I will show you that just in 1 second, but also improves the quality of life of patients. These were patients who were followed up over a 1-year period before and after inclusion in the multidisciplinary approach project, and they all reported improvement in quality of life. So that's the way to improve, one of the ways to improve quality of life as well, along with, let's say, investment in ancillary and supportive care, which are central components in chronic GvHD, even more than in acute. And this is confirmed by the whole document that exists by the NIH effort on this ancillary and supportive care, which is directed at organ-specific control of symptoms or complications of GvHD and its treatment. And there's really much that we can do with local therapy. There are many things in oral, skin, in eye GvHD that are being used. So platelet gel, autologous serum, scleral lenses. This is something that we have tried, but also some other innovative approaches. For several years now, I've been mentioning the amniotic membrane transplantation because I think this is what was another success of this multidisciplinary approach that we started in Zagreb, because collaboration with specialists as an ophthalmologist led us to the use of an innovative approach of amniotic membrane transplantation in severe GvHD of the eye, and that was the used in the first patient that I showed with severe GvHD of the eye. This was proposed by our ophthalmologist. We, of course, never heard about it, but this is something that is used in ophthalmology for burns, for infections. It is very attractive because you have it commercially available, has no HLA antigen, so no fear for rejection. And he said, well, let's do an amniotic membrane transplant on this patient. And afterwards, we really did it on her and many other patients. It is practical because it's just suture to the eye, and then it dissolves over 2 weeks. So nothing needs to be reoperated, no need for immunosuppression. And it works in several ways. One is actually is as a patch. It prevents eyelid from friction, so it's a mechanical protection. It is rich on cytokines, which actually promote epithelialization, and also it probably has some prolonged immunosuppressive treatment, because what we have seen in our patient, it actually has prolonged effect on the chronic GvHD of the eye. So what about some of the perspectives, which I will finish with? Well, of course, nutrition. I will not go into details, but vitamin D is something that we should not forget in these patients. There is consistent association even with development of chronic GvHD with lower vitamin D status pre-transplant. And some retrospective and prospective data on how vitamin D supplementation actually can decrease even the incidences of chronic GvHD, but we do it also to prevent many other complications. There's also some role of microbiota probably here as well, although we are not here talking about intestinal GvHD and FMT, but there were some trials with microbiota modulation with prebiotics, postbiotics, and probiotics. Giving patients, let's say, food for bacteria, which have shown to decrease some incidence. So this is something that, of course, is being studied now. And two other important things is not to forget about is rehabilitation. So classical physical therapy, but also some specific therapy. There's some data on patients with systemic sclerosis, where actually rehabilitation of facial involvement, and that's even randomized data together with some home exercise can be effective in helping them in mouth opening and decreasing the skin GvHD score, and also learning them of many adaptive measures which can make their life easier. At last but not the least, we should think about psychologists and their help in managing our patients. This doesn't need to even be face-to-face always. This is a very, I would say, inspiring study, and it's called Inspired, of online modalities, of telehealth modalities for improvement of quality of life in general in survivors, where there's an online site, and there's a course, there's definition of problems at the beginning, and then a problem-solving treatment over the phone. This has been developed by Fred Hatch and renewed Professor Karen Sirjala, where this kind of program actually improves depression and distress in long-term survivors. And that is, of course, the goal of our goal in chronic GvHD patients as well. Okay. And with this, I thank you.
Thank you, Zinaida. Very complex area, really, and you have very well reflected that in your presentation. It is now open for questions.
I mean, obviously, the most severe and perhaps the more unattended organ, even with the new drugs, even with the axatilimab, which looks quite promising and good, but still you get like 47% overall,
Yeah.
but then 13 is complete response, and the rest is all partial response. So we'll have to see. What is it that you do with your lung GvHD patients?
Well, the patient that I've shown, well, I mean, probably some of the actions should have been done earlier.
Earlier.
And it's not always easy because you are always fighting infections, and sometimes you're fighting mixed chimerism and minimal residual disease, and then you can have both. And then probably we should have been more active. And I believe that the last moment was already too late. So what we were discussing, I don't have experience. We haven't done the lung transplantation in GvHD patients because normally they should be 5 years. That's the protocol, at least in Croatia, 5 years after the diagnosis of their malignant disease to be a candidate for lung transplant. But we have doing some research, and I think that might be presented in later on talks about with Saskia Boss. She did a study in EBMT on lung transplant. I don't know if you have any experience, but all these actions and all these drugs that we now have to be studied earlier, because in this case I think it was everything was a bit too late. So with now those potent drugs, if we don't wait maybe the fifth line, then we might have a better chance to save this kind of a patient before transplant, and maybe then even taking the chance of increasing the chance of relapse. But I think that this might be more our fear than the real worry. So maybe we should be more aggressive, although chronic GvHD is not perceived as an aggressive disease. But with those severe forms and lung and sclerotic, once it's too late, it's too late, because fibrosis is partly irreversible.
Mm-hmm. Yeah, I mean, we got very little experience. Right now, we've got an active young fellow who's received a lung transplant weeks ago, 3, 4, 5, something like that, weeks ago. But that's one, and the previous one was years ago. So it's rare. The area that I think is worth considering, because all the drugs that come to us come from the GvHD world, and then you see how they work on the lung part of the GvHD. Our lung transplant colleagues have lots of fibrosis and have a lot of lung fibrosis, and that's a different path. It's different companies, it's different even mechanisms of action. So I wonder whether this part of the field, rather than expecting that the standard GvHD drugs, even the very anti-sclerotic, antifibrotic, might be very successful. Maybe a way to do this would be looking into what is it that our colleagues are using into pulmonary fibrosis, into parenchymal, interstitial fibrosis, into these things, to see whether that's applicable to also our type of fibrosis, which is obstructive, but also parenchymal fibrosis in many cases. So that's also.
And also, I think, I mean, crucial is to involve a pulmonologist, what you did greatly by also, because Saskia is she's going to give a talk. So I think also bringing them in our team is because, to be honest, sometimes they might understand these things better, and maybe they can act faster. Also, one point is probably moving these drugs a bit up front, and also the potential combinations, because this is what we are not aware of. We have, let's say, accidental combination, because we keep one drug until we taper it off if it doesn't work, and then we have combinations which show us that these combinations are not toxic. But like real combinations, putting the drugs in the same time, that would maybe work. But of course, we still do not have those drugs readily available, at least.
Thank you.
More questions. Okay, I go with one. Actually, following the comment from Rafa, unfortunately, pneumologists have not a single drug that actually works in lung fibrosis. So, unfortunately, I don't think we have a lot to learn from that side, particularly in at least from our perspective. If we have a patient with lung involvement, we try to put him on belumosudil, and after that, try with the other things. But my question is regarding also lung involvement is what is your experience regarding the evaluation of the involvement? Because the spirometry, you see patients that clinically get much better and it doesn't move. I guess it is a good strategy for making the diagnosis, but not for the follow-up.
Yes.
What's the experience?
Yes, you're right. And I mean, at one point, you do not even want improvement. If somebody is stable, that's good enough, and a bit clinically better, so that's good enough. Yes, it might be, of course, not ideal method, but it's like in, I think, all chronic GvHD, we need to involve patient-reported outcomes in evaluation of outcomes, because otherwise, even we are just we cannot decide if it's working or not. So maybe actually this is something that we need to include. Also, patient-reported adverse events as well, because when we are reporting the adverse events, that we are under-reporting them for sure. So I think that's the path in the future for sure. That's what already FDA is doing. So including patients in evaluating outcomes.
Mhm. You have shown us in a slide showing the overall results with the new drugs. Basically, they look quite similar.
Similar, very similar.
Yeah.
The only difference is that we had many previous lines for the second two drugs, but otherwise it looks very similar.
So when I see those data, I wonder whether they are really similar, or the question is that really, again, we don't have the appropriate manner to monitor the outcome of the patients. And at the end of the day, most of them are partial responses.
Yes.
And then you see the slide with
And
PRs
then
and
what do
all
you
are
do?
PRs. So
What do you do with partial damage?
exactly. So
Then it means that you have to add on something else. So
yeah.
yes, I agree, but the good thing with GvHD that it does calm down in a bit in some time, so you just need to wait for that moment. You need to keep up for that moment.
Okay. Actually, that was going to be my next question for you. When do you just wait for the right moment, or when do you consider you need to hurry because you see that the patient is getting worse and worse, particularly with fibrotic lesions? There are different phenotypes of patients.
Yes.
So do you somehow do you use any specific signs or symptoms to decide when to move faster or not?
Well, that's a hard question.
It is.
I don't know, so many elements. For example, this specific patient had so many infections that we were like kind of blocked to add on something. So sometimes there are things that are, let's say, affecting your decision. But for some, you mean some kind of specific clinical sense of that something is going to get worse, right? That's what you think. Not sure. The feeling.
That's clearly an open question to be answered. Okay. Any other questions? So if not, thank you. Thank you very much for your talk. So now Simon Mendez Ferrer will allow us to move to another different topic and go deeper into the biology, and particularly his first talk today. He will go on tomorrow. Will be on the bone marrow niche, which he is a very worldwide recognized scientist and author. Thank you, Simon.
Thank you. Well, first, congratulations on this big achievement, and I want to extend it also to the whole hematology team and the hospital, because it really takes such amount of people, hard work to get to this point. And thank you for the invitation here, but I also need to make two disclaimers. One is that I'm not absolutely not an expert in GvHD, so all these GvHD heart-related questions, please defer to the other real experts in the speaking in this session. And the second disclaimer is that I am a biologist, And therefore this talk is going to be very different from the previous talks, but still I hope that you find it interesting and somehow relevant in the context of hematopoietic stem cell transplantation. So essentially, as you know, the main sort of unmet needs in hematopoietic stem cell transplantation in the allogenic setting is that the niche might be not sufficiently accepted in the case of some patients, and the level of engraftment not enough to guarantee a fast recovery in these patients. The development of acute and chronic GvHD extensively covered in this meeting, but also leukemia relapse if the leukemic clone for those patients, leukemic patients transplanted, still remains there, is the main cause of relapse in these patients. So the main goals would be essentially to achieve a really efficient and fast engraftment and recovery of the hematopoietic system, to reduce the risk of GvHD development, and also decrease the risk of relapse, essentially eradicating those leukemic cells that remain in the patient that is transplanted. And in that regard, leukemic cells that are resistant to therapy really shared features with hematopoietic stem cells. They resemble hematopoietic stem cells in many ways. For instance, they are typically quiescent and resistant to antiproliferative chemotherapy, and therefore there is interest in how to sensitize these cells to chemotherapy, and interested in the niche as a regulator of these stem cells. So the niche refers both to the location of the stem cells and the regulators of the stem cell, the molecules that regulate the stem cells. And all these remarkable properties of the stem cells, the multilineage differentiation, their self-renewal over life, and also the migration capacity, which is essential in the context of transplantation. All these properties are regulated by the niche. So we were particularly interested in the pathways that regulate the migration of stem cells, because really the drugs that stimulate the mobilization and engraftment really take advantage of these natural pathways that govern the migration of stem cells. So starting with this problem, of course, the interaction of the stem cells with the niche requires a number of additional molecules that are very well known, and they govern both the mobilization and the engraftment process of the stem cells. So this is a multi-step process that involves the rolling, arrest, firm adhesion, and then extravasation and transmigration of the stem cells previous to their homing and engraftment in the tissue. And in the case of the mobilization, you know very well there are different agents that can elicit mobilization with different kinetics. There are very robust mobilizers, such as G-CSF or cyclophosphamide, but they take some time to elicit this robust mobilization. I think it's still unclear why G-CSF takes 4 days to mobilize stem cells. There are a number of things that need to happen for G-CSF to induce this mobilization. And in contrast, there are very quick mobilizers, such as CXCR4 antagonists, that elicit less robust mobilization compared with G-CSF. So G-CSF, for instance, has to change many things, like induce proteolytic cleavage of these additional molecules, such as VCAM1. Another molecule that is very importantly cleaved by G-CSF treatment is CXCL12. This on not only proteolytic cleavage, but also downregulation of this main chemokine for stem cells in order to have this mobilization phenotype. So there was a lot of interest in trying to understand which cells are really regulating the stem cells and producing these key molecules. And over 20 years ago, it was thought that the main cell maintaining hematopoietic stem cell was this bone lining osteoblast that you can see lining the bone surface. And a number of studies suggested that different molecules produced by this osteoblast were actually controlling the addition and maintenance and quiescence of hematopoietic stem cells. So this involves molecules like angiopoietin 1 binding to type 2 in the stem cell, or homotypic interactions mediated through N-cadherin, or Wnt ligands that were secreted by osteoblasts and activated freeze-up receptors in the stem cells, Notch jagged 1 determining this interaction also with endothelial cells, and alpha-4, alpha-5 integrin binding to VCAM1, fibronectin, or osteopontin, CXCR4, CXCL12, as I mentioned before, and also calcium sensing receptor binding to calcium, which is very high in the endosteal niche where these osteoblasts are located. But together with this discovery of this endosteal niche and the multiple signals that these osteoblasts might be providing to the stem cells, there was also the evidence of that experiments where they eliminated the osteoblasts or they directly changed the osteoblastic function. These experiments actually didn't impact directly on the stem cells. So there were changes in hematopoiesis that secondarily affected stem cells, but not direct impact on the stem cells. And together with the fact that also the development of markers that allowed a better purification and identification of the stem cells, this is, for instance, the SLAM family of markers to label these hematopoietic stem cells, and the realization that the majority of the stem cells are actually not in contact with the osteoblast, but quite far away from the osteoblast and more associated with a sinusoidal type of vessels in the central marrow. So the concept emerged that there was a vascular niche as opposition to an osteoblastic or endosteal niche where stem cells might be located. And this dichotomy between endosteal and vascular niche is really not appropriate because the endosteal surface is really heavily vascularized. You can see here a cross-section of a femur of a mouse where you can see all these blue vessels that actually have mixed properties between arterioles and sinusoids. So these are vessels that connect arterioles and sinusoids near the bone surface, but you can really appreciate how densely vascularized the endosteal surface is. So the stem cell niche is really a vascular niche, but it can be in different locations inside the bone marrow. And over the last years, there's also this developing concept that there might be different niches where the stem cells might have different properties. And it's been postulated that the endosteal niche promotes the quiescence of hematopoietic stem cells, that might enforce this primitive behavior and sort of not an active contribution of these stem cells to the hematopoiesis, but an important role for hematopoietic regeneration after insult. And in contrast, this sinusoidal niche in the central marrow might be hosting the majority of the stem cells, including a majority of the ones that are actively contributing to hematopoiesis and migrating in and out of the bone marrow through these sinusoids that are actually much more permeable for the migration of cells compared to the arterioles, as you know. But another interesting component that was actually linked to the vessels is the nerve fibers. So actually the bone and the bone marrow are innervated by sensory and sympathetic nerve fibers. The majority of these fibers enter the bone marrow through the arteries and arterioles, and then sprout and innervate other regions. And it's not only these vessels that I mentioned, but also transcortical vessels that are quite abundant and frequently neglected that connect periosteum with endosteum. And these vessels actually can carry a lot of in and out blood cells into the marrow. So working on why GCSF was mobilizing stem cells and whether this was related actually to these regulators of the microenvironment, it was shown previously by the group of Paul Frenet that GCSF actually requires the presence of an intact nervous system in order to elicit a mobilization of stem cells, and this was associated with a suppression of these bone lining osteoblasts and the reduction of expression of CXCL12. So because this was really matched to the time when the osteoblast was considered like the important niche cell for hematopoietic stem cells. But also over the years, it's become quite visible that not only the bone lining cells, but also osteocytes that are embedded in the bone matrix that have these very dense dendrites interconnecting each other, osteocytes are required for the propagation of the signals required for the mobilization of stem cells. And in animal models where these dendrites are not densely branched or are not interconnected, then actually these animals fail to mobilize stem cells upon GCSF treatment, indicating that these signals need to be propagated through electromechanical coupling among multiple cells, and this is required really for the mobilization of stem cells. And actually, electron microscopy studies showed this dense coupling of different cells of the microenvironment, connecting the arteries here with the periadventitial reticular cells. And these reticular cells actually have these electron-dense, gap junctions that are showing that this tissue is really electromechanically coupled, and this might explain why these signals can be actually quite fast propagated throughout the bone and the bone marrow. So it's been shown actually that the secretion of CXCL12 as one of the drivers of mobilization and homing actually requires this electromechanical coupling among the stromal cells. So if the stromal cells are disconnected or isolated, they don't secrete CXCL12. So trying to understand how this GCSF works to mobilize and how this is participating through the nervous system, we came across a really serendipitous observation that when we were injecting GCSF in mice, we noted that a group of mice didn't mobilize properly. And actually the reason turned out to be that these mice, by a mistake in the light system of the animal facilities, have been exposed to constant light. And this indicated that the rhythm in the body was actually governing the migration of stem cells. And we went on to show that this migration actually follows circadian oscillations, both in mice and humans, and that you could have 2 or 3 times more stem cells if harvested during the resting period in both species. And this is governed by the molecular clock, but it's really mediated through sympathetic innervation in the bone marrow that through noradrenaline really governs this attraction of stem cells in the bone marrow. So even though these are really basic observations in mice, we think that just optimal timing of apheresis and infusion might in some cases increase the yields of stem cells that can be harvested and the efficiency of homing and engraftment if it's timed at the right period in the patients. So more recently, we demonstrated the role of the sympathetic adrenergic system in the mobilization or regress branch. And more interestingly, we were interested in the homing process because it's more relevant really for the poor engrafted and so forth. And hypothesized that maybe the other branch of the autonomic nervous system could antagonize the sympathetic one and participate in the relation of the homing process to the bone marrow. And indeed, quite interestingly, when we looked at mice with deficient parasympathetic activity, we observed a very specific accumulation of hematoperistem and progenitor cells at the time when the parasympathetic activity starts kicking on and inhibiting the sympathetic tone. So this shows a cooperation between sympathetic and parasympathetic systems in really governing this migration of stem cells in and out of the bone marrow. So this is illustrated in this cartoon where during day and night cycles, you have high activity of sympathetic or parasympathetic systems, which really antagonize each other and promote, in one case, the egress of the stem cells into circulation or their homing back to the bone marrow. And this is through the regulation of chemokines and addition molecules. And particularly for the homing process, we showed that beta-2 receptors, which are not only stimulated through the nerves, but also through circulating adrenaline coming from the adrenal medulla, this beta-2 receptor really stimulated the addition of hematopoietic stem cells, favoring their homing back to the bone marrow at a specific time. And this has been recently taken forward in a study that has shown that actually non-selective beta blockers that are frequently used in cardiovascular disease actually lead to impaired or delayed regeneration of hematopoietic system after allogenic hematopoietic stem cell transplantation. So this interplay between the nervous system within is actually quite dynamic. Some of the fibers that release acetylcholine are not parasympathetic, but are sympathetic. And this is changing during development due to inflammatory cytokines that change the type of neurotransmitter that is released. But within, there are important consequences for the regulation of hematopoiesis. This acetylcholine that is released in the endosteal niche actually favors the quiescence of hematopoietic stem cells. It stimulates the production of CXCL12. It renders these stem cells quiescent, And we think that this is a system really to protect the stem cell pool from proliferative attrition. Because the sympathetic nervous system is a stress response system that in some way, it might trigger migration of stem cells out of the bone marrow for regenerative purposes or upon hematopoietic stress. But at the same time, through this cholinergic branch, it might make sure that you don't exhaust your stem cell pool by protecting a small pool of stem cells that are rendered quiescent through this other signal. So what are sort of what is the relevance of these circadian oscillations of stem cell trafficking? This is a very difficult question considering the small amount of circulating stem cells at any time, but we think that they are both biological and clinical sort of interesting aspects to consider. One is that stem cells are released during the resting phase, and therefore they could perhaps compete with other stem cells and displace from the niches stem cells that are less fit. It's been shown that these patrolling stem cells that are going into circulation infiltrate peripheral organs, and some of them might provide a source of differentiating cells that protect the body from infections or other types of insults. And then they could establish new niches as they come back to the bone marrow. But there are also important sort of clinical implications. One is that even today we cannot really expand stem cells efficiently ex vivo, therefore finding the cues coming from the niche might be useful. And the other thing is to try to improve the engraftment in poor engrafter patients. And in this regard, there is the potential for new pharmacological approaches, such as adrenergic receptor, as I mentioned before, or simply by timing the harvest and infusion of stem cells, even though these rhythms are not only depending on the time of the day, but also on other aspects that govern the clock in the body. So we were trying to understand which is then the most important cell in regulating the hematopoietic stem cell. And for several reasons, this could not be the osteoblast, because the osteoblasts don't express this beta-3 receptor that is regulating actually the attraction of the stem cells. They also didn't have the highest levels of CXCL12 compared with other stromal cells. And also they were not in the right location because they were next to the bone surface, not really in the perivascular location. And through a number of studies, we demonstrated that mesenchymal stromal cells that we identified using this marker, but these are bona fide skeletal stem cells. These stem cells actually fulfill the criteria, and they are associated with the nerve fibers, they're associated with the vessels, and they regulate the attraction of stem cells in the bone marrow. So this is just a demonstration that they are highly enriched in the MSC capacity. This is defined as the capacity to grow these fibroblastic colonies and differentiate into osteoblasts, adipocytes, and chondrocytes. But at the same time, they also have features of niche cells for hematopoietic stem cells. And this is just an example where we eliminated nestin positive cells in the mice, just expressing a toxin, diphtheria toxin, that kills about 50% of the cells in the mouse, and we find a similar 50% reduction in the number of hematopoietic stem cells, indicating that this is strongly suggested that these are important niche cells for hematopoietic stem cells. So based on these criteria, that they had high enrichment in CFUF activity, capacity to initiate colonies as other stem cells, robust multilineage differentiation, and self-renewal in serial transplantations, and some contribution to osteochondral lineages. They fulfill criteria as skeletal stem cells, but at the same time, it's one of the first examples where you can have a tissue stem cell that actually behaves as a niche for another stem cell in the same tissue. And the criteria at that time were that they actually localize very close to hematopoietic stem cells, that they regulate the behavior of these stem cells in terms of addition, in terms of migration. And if you transplant hematopoietic stem cells into mice that are conditioned either by irradiation or myeloablation, the stem cells rapidly home near nestin positive cells. And this is, again, a strong reason. And there is follow-up work by other people showing that only the stem cells that remain next to the nestin positive cells can really remain as stem cells and don't differentiate over time. So there is, as I said, interesting in considering these cells for expansion of stem cells. This has been attempted in the past expanding these plastic adherent MSCs that are very easy to grow, but as the drawback is that the cells that are growing are not really pure stem cells, but they are very heterogeneous in their potential, their self-renewal capacity, and also their capacity to support hematopoiesis. This was taken to a phase 3 study, I believe, where they compared expanded cord blood on plastic adherent stromal cells with non-expanded cord blood, and then they observed there was a faster recovery of neutrophils in the cord bloods that had been expanded on the MSCs, but over time they also acknowledged that the long-term engraftment was uniformly coming from the unmanipulated cord blood, indicating that the stromal cells were really not able to maintain the cord blood stem cells ex vivo under these conditions. So we tried to work hard on other ways to preserve these primitive features of the stromal cells in order to preserve hematopoietic stem cells in culture and even being able to expand them. And we came up with non-adherent culture conditions where MSCs grow as these spheres that are under cytokine stimulation and some growth factors preserving stem cells. They are able to maintain, to some degree, human cord blood-derived hematopoietic stem cells that are multi-lineage differentiation potential, and they can sort of reconstitute immunodeficient mice to a certain degree. So altogether, I think this is sort of a convincing evidence that MSCs are important niche cells for hematopoietic stem cells, and this has been confirmed through a number of studies by different groups using different markers that at the same time has brought a bit of confusion and noise to the field, because people tend to highlight their favorite marker and sort of claim that their population is the real niche for hematopoietic stem cells and not the other population. But I think where this controversy is really solved by multiple studies that have shown that we're essentially talking about the same MSCs, but it's just the strategic tools that have been used and the misinterpretation of the results. For instance, there is a discrepancy between the populations of MSCs that have been characterized, which are small and only comprise a subset of those populations that have been targeted by crystalline to functional studies. So obviously there is a huge overlap that has been neglected, and therefore the small differences have been emphasized when we are essentially talking about the same type of stromal cells. So altogether, this suggests that mesenchymal stem cells are important regulators of hematopoietic stem cells for the migration, but also for the maintenance, and that this regulation is actually interestingly coordinated through the nervous system. In terms of potential implications for disease that this might be related to, one of them is in patients that have dysautonomia, like diabetic patients, and it's been shown that these patients actually don't mobilize well. And one of the reasons that they don't mobilize well might be this dysautonomia that they have. For instance, these are mice models of diabetes rendered diabetic through a streptozotocin treatment. Here with the striped lines, you can see the diabetic mice, and these are the control mice, and you can see that GCSF very effectively downregulates the expression of these additional molecules in the normal mice, but not in the diabetic mice. So there is a failure to communicate with the stroma, and part of this failure we think is related to this autonomia. There is a disruption in the innervation that can be actually rescued. This regulation of CXCL12 downstream of GCSF administration can be rescued by a beta blocker, specifically targeting beta-3 receptor. So altogether, this shows this interaction of MSCs with the nervous system and other regulators that might be important, particularly for the migration of hematopoietic stem cells, and that sort of working on these pathways might allow us to increase the mobilization yield, but most importantly, the engraftment during transplantation. So the other really severe complication is the leukemia relapse that mostly comes from leukemia stem cells that are still dependent on the support of the stromal cells for their survival. And there are different models where it's been postulated that the niche can contribute to the malignancy, progression, resistance, and development, One of them is the acquisition of alterations, either genetic, epigenetic, or functional, by the niche cells that might predispose for malignancy development. And the other non-mutually exclusive possibility has been that the leukemia really transforms the niche into something that promotes leukemia development, progression, of resistance, and impairs normal hematopoiesis. So for the first one, the evidence comes mostly from mouse models, not so much from patient data, but it's quite strong in the sense that multiple types of alterations in the niche or in non-hematopoietic cells, interestingly, always lead to a same type of myelodysplastic or myeloproliferative-like syndrome, which is really coming from alterations in the environment, not in the hematopoietic cells. Although most of these alterations have not been really demonstrated in patients to be drivers of malignancy progression. But there is much more evidence in contrast to the niche remodeling by the leukemic cells as an important driver of disease development and resistance. And this involves multiple processes, such as the reprogramming of the stromal cells, the inflammatory process, hypoxia and angiogenesis happening, on the activation of survival pathways for the leukemia cells, their protection from chemotherapy, the immunosuppression, which is again very important in the context of immunotherapies, eventually leading to therapeutic resistance. So it's just a snapshot that is actually not updated, but just to give you an example of multiple clinical studies that have been targeting this interaction with the niche as a way to either sensitize the leukemic stem cells to chemotherapy or decrease the relapse after transplantation. So there are multiple ways as how the microenvironment supports the survival and resistance of leukemia cells that might be causing relapse after transplantation. Different cell types such as endothelial cells, osteoblasts, MSCs, or adipocytes can provide metabolic support to the leukemia stem cells in the form of different factors or metabolic substrates such as fatty acids. But together with this metabolic support, there are also survival pathways that are modulated by the niche, such as PKC beta or BAF and APRIL, that are well known to provide the survival of the leukemic cells. And this is an interesting interplay between the stromal cells per se and the immune system. And it's been shown that the innate immune system, for instance, can render the stromal cells inflammatory. This is mostly driven through NF-kappa beta. And these inflamed stromal cells are poorly supporting the normal hematopoietic stem cells, but instead tend to favor the expansion of the leukemic cells. And this is something that I will expand more tomorrow. And there are specific ways as why and how the stromal cells might provide resistance to therapies. One of them is by the secretion of cysteine that allows the leukemic cells to produce glutathione, which is a key detoxifying enzyme that then allows the leukemia cells take on all these drugs and survive the oxidative stress associated with chemotherapy treatment. So together with this sort of metabolic reprogramming of the environment, there is a huge revival of the immune microenvironment in the context of hematopoiesis, of course. This has been mostly developed in the context of solid tumors, but is currently being recognized as an important driver of immunosuppression that might provide immune evasion to the leukemic cells, and also maybe some sort of resistance to the immunotherapies if they find an immunosuppressive microenvironment. So obviously there are a number of pathways that I cannot go in detail, explaining the immune evasion of the leukemic cells. But together with these direct interactions of the innate and adaptive immune system with the leukemic clone, there is also the interesting possibility to explore in the future of the crosstalk of the stromal cells with the immune system in this immune evasion mechanism. We heard from Rafael, there is a lot of evidence that expanded MSCs in culture, infusing the patients, can be of benefit in some cases for GvHD and other chronic inflammatory conditions due to these immunomodulatory effects. But comparatively, we know way less about the potential role of the endogenous niche or the stromal cells in immunomodulating the system providing potential immunization to the leukemia that is developing, or after the patients have been treated with CAR T therapies, for instance. So it will be interesting in the future, of course, explore this potential interface or crosstalk between the stromal cells and the immune system in creating this immunosuppressive microenvironment in situ, and how to prevent it, and also to sort of maximize the efficiency of CAR T therapies. So I think I talked enough for today, and just acknowledge, the drivers of all this research that I showed. Tremendous, very talented team, illustrated here with the help of many collaborators and funding agencies. And thank you very much for your attention.
Excellent talk and excellent work, Simon. Congratulations.
Thank you.
We have some minutes for questions.
Thank you, Simon. It was a very nice talk. I have a question that has come to me when I was hearing your talk regarding the influence of the mesenchymal stem cells in the niche engraftment. Have you or anyone thought about using mesenchymal stem cells concomitantly with the transplant in order to, mesenchymal stem cells are also a therapeutic agent for graft-versus-host disease, or maybe as a prophylactic for graft-versus-host disease, and to enhance engraftment? And then in that case, would it be systemic application, or would you need to do it intrabone? So the mesenchymal stem cells intrabone.
That's a great question, Alfonso. Thank you very much. So there is, it's been tried very hard. The main hurdle is that MSCs that are infused intravenously seem to be quite potent in having these immunomodulatory effects, but most of them get trapped in the lung microcirculation and still can have very sustained, long-lasting effects, which has puzzled the field for a very long time. So it seems like there is quite solid work from Francesco Dassi at King's College and other people showing that MSCs really have to die, and these apoptotic cell bodies are really taken by macrophages, and this causes the reprogramming of the macrophages towards an immuno sort of suppressive role. So it's really the interaction of the infused cells with the immune system that seems to be driving this effect. And for that, you don't really apparently need to have local engraftment in the injured tissue, but it's sort of a systemic effect of MSCs. This is, however, different from the effects on engraftment. So because they don't engraft in the bone marrow, it's only the local injection that has been shown the capacity to favor or increase the engraftment of hematopoietic stem cells. Either that, or some people work with systems where you can have an ectopic niche, like an ossicle that you put under the skin, and then the stem cells would go to that ossicle. And once they've been sort of interacting with the stromal cells in that system, they are now able to go to the bone marrow, engraft, and reconstitute the system. So there has to be some education that only seems to happen if the stromal cells are really in the bone marrow and not in circulation. So that's what people have been trying.
More questions? So I have a couple of them. Simon, how could we tailor the conditioning regimen in order to make the MSCs in the best or the most fit situation regarding the expression of CXCL12, wherever, to facilitate the engraftment? Is there any possibility for us to harness the conditioning in this regard?
I think so. Yes, also related to the previous question, I forgot to mention that other ways, smarter ways that people are trying to improve the homing of MSCs that are infused intravenously is to promote their addition to the bone marrow. And there is this work from Robert Saxton and other people promoting the fucosylation of E-selectin that then makes these cells really eager to engage with the bone marrow. And in that case, you can have much more efficient homing. And then, these cells might foster the recovery of the hematopoietic system. In terms of the conditioning, it's a very important question, because actually it was considered that this, the conditioning, the niche doesn't care, and it's radio resistant, it's chemo resistant. So you just, bomb the patient with all sorts of drugs. These cells will survive and will allow, the hematopoiesis to be reconstituted. This is only partly true because the cells are really damaged by the conditioning regimens, and it's been shown that it has to be recovered from this damage in order to drive regeneration of the hematopoietic system. And this is something that I will expand tomorrow more in the crosstalk of the stromal cells, also with the leukemia cells in the context of transplantation.
Okay. Some more question? Actually, I have another one because there is a very practical data, and actually, I would say a very important one, which comes from your studies regarding the effect on the beta receptors. And now we need to be very careful regarding what specific drug are we giving to the patient regarding the beta blockers, which is a very commonly used drug, actually. Any comment on that?
Yes, so it's there are many patients treating with beta blockers, and clearly we and others show that beta receptors are modulating the expression of these chemokines and also the addition of the leukocytes and the hematopoietic stem cells to the endothelium. So clearly, if there is an excess of beta blocking, in the context when these cells need to have, engage with the endothelium and then transmigrate, there will be, suboptimal homing and engraftment for sure. So it's been formally demonstrated through this association study where they confirm our findings and also suggested that patients chronically treated with beta blockers for a long time, they have a delayed recovery of the hematopoietic system. So I think something to consider, particularly if you suspect that the recovery won't go, very quickly in that patient population. Try to avoid, obviously, concomitant use of beta blockers. I presume that this is mainly due to beta-2 receptors, and these receptors are desensitized relatively quickly. So I presume that these patients goes off treatment, this effect could be sort of reverted, and then it shouldn't be a major issue. Other receptors are more resistant to the sensitization, but not this one. So for the homing and engraftment part, I think that perhaps removing that drugs during that period of time of conditioning and transplantation should be perhaps enough.
Always that I think about MSCs and the immunomodulatory effect, not only the effect on the maintenance of the hematopoiesis, I always think the same. I mean, they are in the wrong place in order to favor the graft versus leukemia effect. So the marrow is plenty of MSCs.
Exactly.
How could we, experimentally demonstrate whether or not they play a role against the immune effect of the transplant, since they are in the wrong place? This is the bone marrow niche where the leukemic cells are located.
Right. So they might be providing an immunoprivileged environment to the stem cells, but maybe also to the leukemia stem cells, and therefore it might be a window of opportunity if we disrupt this immunosuppressive mechanism, to. Yeah. So I think it's surprising that it's so little work done on sort of the endogenous cells as opposed to the infused cells. Just thinking about the possible role in this process.
Okay. So if there are no more questions, thank you very much, Timon. We will have the opportunity to hear you again tomorrow. And now we're going to have lunch. So for all of you that are connected online, the afternoon session will be starting at 4, but will be held in Spanish. For the rest of the people who want to join in English, tomorrow at 9 o'clock, we will be meeting you again here with more talks and more things to learn.